thank you very much for the invitation to speak at this meeting. And I'm sorry that I can't be in Argentina in person today. My name is Professor Anisur Rahman, and I work at University College London in the UK. And the title of my talk is Cardiovascular Risk in Lupus. And I have no relevant disclosures. Cardiovascular disease is a problem in patients with SLE, and you might be surprised to hear that, because SLE affects primarily young to middle-aged women, and in that sort of demographic, you would ordinarily expect the risk of cardiovascular disease to be very low. But the prevalence in patients with SLE is actually much higher than you would expect. So there's a lot of evidence for that from many different studies. For example, in a large study of almost 10,000 patients, about 25% of the deaths in that study were due to cardiovascular disease. So CVD is important in patients with lupus, much more important than we think it might be based on the fact that the patients are younger women. And it's not just symptomatic cardiovascular disease either. Vascular ultrasound studies in many different places have shown that at least 30% of patients with lupus have asymptomatic atherosclerosis. They have plaques in their blood vessels. So we know that cardiovascular disease and atherosclerosis exist in patients with lupus, and we don't really know what to do about it. And that's a problem. I'm illustrating that by this slide. Now, this slide isn't actually a picture of patients with lupus. This slide is a picture of the audience at a Justin Bieber concert. And the reason I've chosen this slide is that I wanted a picture of a crowd of mainly young women. Maybe 90% of the people in the crowd would be women at a Justin Bieber concert, perhaps. But I want you to imagine that this is a crowd of young women with lupus. And we would know that some of these young women at some point would be destined to have cardiovascular disease, heart attacks or strokes, much younger than they should. And we want to stop that from happening. And the big problem is we don't know which of the women in the picture are going to have that event. We can't quantify the risk on an individual basis. But you might say, well, hang on a minute. Why is that a problem? Because we know how to manage cardiovascular risk, because it's very well known that things like diabetes and smoking and blood pressure and lipids are the main risk factors for cardiovascular disease. So why don't we just make sure we manage those risk factors well in all our patients with lupus? There's a problem. Now, there's another Rahman, another researcher with the same name as me in Canada, and he published a paper showing that patients with SLE and cardiovascular disease have fewer conventional risk factors than non-SLE patients with cardiovascular disease. In other words, these conventional risk factors are only telling us part of the story. And Estelle, another Canadian investigator, did a very complex statistical analysis of 263 patients and showed that even if you allow for all the conventional risk factors, there's still an 8-fold increased risk of stroke and a 10-fold increased risk of MI. So even if you do the best you can with conventional risk factors, you still won't fix the whole problem. But that doesn't mean we have to ignore the conventional risk factors, because they are present in patients with SLE. So between 17 and 21% of patients with SLE, from various studies, they tend to have higher triglycerides, though not necessarily higher LDL, and hypertension is common. And we know what to do about these things: smoking cessation, statins perhaps, treating blood pressure. So we can't ignore these risk factors, even though we know they're not the whole story. So what can we do about cardiovascular risk in patients with lupus? 3 things, I'd say. Number 1, let's be better at managing the conventional risk factors. Stop people smoking, control their blood pressure, control their lipids. Now, some people argue that disease activity itself is increasing atherosclerosis in patients with lupus. The idea here is that there's a lot of inflammation going on that leads to changes in the walls of blood vessels, leading to increased atherosclerosis. So this theory would say that if we suppress inflammation in patients with SLE, give them more steroids, more immunosuppressants, then long-term there will be a benefit because they'll have less cardiovascular disease. But there's a counter-argument as well, which is that increased steroids, by increasing things like obesity and high blood pressure, will increase the risk of atherosclerosis. So is increasing the steroids good, or is it bad? So it's all very difficult to do these 3 things. So first, looking at the conventional risk factors. Now, in the general population, we decide who to treat with statins, for example, by using risk scores. And the risk scores are based on the Framingham risk equations. But the Framingham risk scores always underestimate the true risk of cardiovascular disease in patients with SLE, because those risk equations rely quite heavily on male sex and increased age. A lot of our patients are younger women. In fact, we did a study about 10 years ago, and in 308 patients of our cohort at University College London, only 35 had a 10-year risk of about 7.5%. We know real risk is higher than that, but the risk equations are underestimating it. But I'm going to show you in a minute a new risk equation which may help. And this idea that we're going to change the immunosuppressive treatment, even if the patient is apparently well, on the basis that we reduce their CVD risk in the future, it's kind of hard to justify. Can we say to a patient, take more steroids or take more mycophenolate, not because you feel ill, but because you might get less chance of a heart attack later? We're going to have to be pretty sure that that's true. So what is this Q-risk3 algorithm? This is a new risk algorithm published by Hippersley, Cox and colleagues from a large amount of data from a United Kingdom population database. And the new things compared to the Q-risk2 algorithm, which was before, is that this one includes SLE and chronic kidney disease and steroid use, all things which are relevant to patients with lupus in the risk equations. In other words, people with lupus will have a higher risk based on this equation than they did on previous occasions, on previous risk algorithms. Now, what they found in this paper was that the overall risk assessment for the population doesn't change much because most people in the population don't have those things. But the small proportion of patients with SLE, about 1 in 1,000, their risks, their calculated risks, did increase. So using Q-risk3 would help us to identify more patients at risk of cardiovascular disease who have lupus. But once we've identified them, what are we going to do? So I said we should be better at managing the conventional risk factors. How much can we actually gain from that? So in our patients in University College Hospital London, we did an audit in 2015. There were 309 patients, mainly women, and you can see we have quite a mixed ethnicity in our cohort. So sure, we found these conventional risk factors, but could we do anything about them? 30, about 10% smoked, but only one of them accepted referral to smoking cessation. 29 out of 30 said, we're going to carry on smoking. They wouldn't stop smoking, even though we'd identified them as smokers. We didn't find undertreated hypertension as a big problem, probably because we're very assertive at treating renal disease. So most people with renal disease are on an antihypertensive. And we did find a lot of people with raised lipids, and most of them weren't being treated. So this may be an unmet need. We could maybe do better at this. So the message from this slide is, yes, maybe we can do better, but it requires the patients themselves to comply with it. Maybe they won't. So we could do better if we could identify lupus patients at high risk of cardiovascular disease. So going back to those 29 smokers, if we had a way of measuring their risk, if we said to 15 of them, say, look, we've measured your risk and it's particularly high, please stop smoking, maybe we would do better. So if we could identify the high risk patients, we could do better. And this whole idea of controlling disease activity, if we identified very high risk patients, maybe that would help us to make a decision. Maybe we would say about those patients, actually, we don't want them to have even minimal disease activity. We want to increase their treatment so their disease activity comes under control because we think it will help their cardiovascular risk. So how do we identify the patients at highest risk of CVD? Going back to my picture of those young women in the crowd, how could we identify which of them were at the highest risk? And the answer to that is we need biomarkers. We need something we can measure in each patient. So this is a kind of scheme that we could use. Now, once I showed this in a talk and somebody tweeted, this is how they do it at University College Hospital London. It isn't. We're not doing this now. This is an idea that people might do in the future. So let me take you through it. We start in all our patients with lupus by assessing their conventional risk factors, maybe once a year. People who have high risk, for example, they're hypertensive and smokers and have high lipids, go straight to aggressive management of the conventional risk factors. Okay? That's simple. At the other side of the slide, people with low risk, they don't have any risk factors at all that we can find. Do we have any reason to be worried about them? For example, they've got persistently high disease activity. If not, well, then we just observe them. If we do have some other reason, then we go to these biomarkers. And the people with a moderate level of risk, maybe a single factor, at a moderate level, well, then with those people, we go to the biomarkers. And the biomarkers enable us to divide this group into high risk and low risk groups, which are either observed or have aggressive management. So checking the biomarkers becomes very important. So what biomarkers could we use? And we can divide these into two groups: imaging biomarkers and serological biomarkers. So imaging biomarkers are where we use imaging to actually look at blood vessels, see if there's any plaque in them. So they give direct information about how much atherosclerosis there is. And I'll show you that there's some evidence that these imaging biomarkers can actually predict cardiovascular events. But the disadvantage is it's quite tricky to do this. You can't do this at every visit. You can't ultrasound somebody's carotids at every visit, and it can be operator dependent. Two different scans might get different results. And if we're looking at something which helps us to decide how to treat patients, how much steroids to give, we don't have any good evidence that these imaging outcomes are related to disease activity. Now, serological biomarkers, things you can measure in a blood sample, are much easier to measure repeatedly. You can test them for that every time they come. Some of them do have an association with disease activity, but we don't have any really compelling evidence that these predict cardiovascular outcome. So what serological biomarkers have been suggested? Well, disease activity markers like anti-DNA and complement don't seem to have any consistent relationship with CVD. Antiphospholipid positivity, very opposite, since this is a conference all about antiphospholipid antibodies. There are lots of people who have shown an association. In other words, that people who are antiphospholipid positive have an increased risk of getting cardiovascular disease, but it's not a universal finding. Not everybody finds this. I would recommend this systematic review by Senias and colleagues in Canada. They reviewed 101 studies and they found a lot of different predictors, but the most consistent serological issues were antiphospholipid antibodies and renal disease. But the evidence isn't strong enough that we could say, for example, that everybody with antiphospholipid antibodies should go into statins or aspirin. It's not strong enough for that. What about imaging biomarkers? So lots of different imaging techniques have been published in patients with SLE. Vascular ultrasound, probably the most commonly used, and it's usually the carotid arteries which are scanned. Coronary CT has been published, electron beam tomography, and cardiac MRI. And of these, ultrasound is the most promising and has the most data. So why is ultrasound the best? It's non-invasive, there's no radiation involved, it's relatively quick and easy and safe. And there are results from multiple groups showing that you would pick up a lot of people. 30 to 40% of patients with SLE with no history of CVD have carotid plaques. You can measure lots of things. You can measure the thickness, the intermediate thickness, or IMT, the number of the plaques, the area of the plaques, the echolucency of the plaques. You've got lots of outcomes you can measure. It's quite an attractive thing. And there's evidence that it will actually help us to predict the highest risk patients. This is a paper from Sue Manzi's group in Pittsburgh, published about 10 years ago. They followed about 394 patients with SLE. They were all women. They were followed for 8 years. At baseline, at the start of the 8 years, they measured carotid IMT and plaque, and then they told us what happened to them during the 8-year follow-up. What they found is that the people who had a thicker IMT at baseline had an increased risk of cardiovascular disease by 1.4 times. And people who had plaque in their carotids at baseline were 4 times higher and more likely to have a cardiovascular event than the people who didn't. So this suggests that looking at the plaque can help us to identify the higher risk patients. So we've taken this on and done something different. Starting in 2011, we scanned 100 patients with SLE who didn't have any history of cardiovascular disease. Now, we did something a bit different than most other people. We scanned both the carotids and the femorals, so 2 carotids and 2 femorals. And we did this because some patients are known to have only femoral disease. You would miss them if you only scanned the carotid. And we measured more things. We did measure the IMT, we did measure a number of plaques, but we also measured the area of plaque and the echolucency. Now our patients were 95% female, mean age of 45, and mixed ethnicity. Just like most other people in the field, we found that between 30 and 40% had plaque. In fact, 36 out of 100 had plaque, and 7 of those had only femoral plaque. In other words, we would have missed them if we didn't scan the femorals. We did a rigorous statistical analysis, and the only 2 factors associated with having plaque were age and triglycerides. But a really interesting thing came out when we looked at area. So this is the area of all the plaques in a patient. Now this is associated with age, but it's also associated with taking prednisolone at a dose of more than 5 milligrams a day. So being on high dose prednisolone gave these people, was associated with more plaque, a greater area of plaque in these people. This was a new finding that people hadn't shown before. So we went on to do a follow-up study, which we're just about to publish, and there was a mean of 7.5 years post-scan for all these 100 patients. And we found out who had had any cardiovascular events defined as you see here. And we corroborated those very clearly by looking at the records. And when we did an analysis to see what things at baseline predicted who was going to have events. So 7 out of 100 patients had events during that 7.5 years of follow-up. 5 were coronary, 2 were lacuna strokes, all were women, and they were quite young. All of the people who had coronary disease had plaque at baseline. Neither of the 2 stroke patients did. So plaque at baseline was a predictor for coronary disease. And when we went into that statistically, the big things which predicted who was going to get a coronary event were the plaque area, not the IMT, the plaque area, the number of plaques. Now, you remember I said we did both carotids and both femorals. So there are 4 possible sites of plaque. And people who had 3 or more sites affected by plaques had a 10-fold increased risk of having an event, 10-fold increase. And a total plaque area greater than 16 had a 6-fold increase in risk. Disease duration was also predicted, but you can see that this measurement at baseline gave us a strong predictive value for who was going to get the event. So this total plaque area is very interesting to people who work in this field outside SLE. Many people who work in the field of managing cardiovascular risk like total plaque area because it's a more sensitive marker than IMT, because it's 2-dimensional. So if you're looking at the change in area of something, it's going to change more than just the change in thickness of something. So it's 2-dimensional. And we've shown that it's a predictor of cardiovascular events in our cohort. But I must say that this is just a small study. It's only a single center. We might be wrong. It needs validation by other people. But very interesting and very relevant, because these investigators are in Córdoba, exactly where you are. So investigations in Córdoba in Argentina have looked at a group of patients who don't have lupus, but have high risk of cardiovascular disease due to metabolic issues. And what they did in this population, they did intensive management of CVD risk factors, and they showed that TPA is actually a modifiable measure of disease risk. In other words, about 30% of these patients, their TPA went down when they modified their risk factors, but about 50%, the TPA went up. So this means that maybe if we measure TPA, we can actually follow it over time and look at what we're doing to cardiovascular risk. So my conclusions: increased cardiovascular risk is a problem in patients with SLE, even though so many of them are young women. We mustn't forget those conventional risk factors. We must pay attention to smoking, lipids, and hypertension, but that's not the whole story. We need to identify the patients at highest risk, both to manage their conventional factors better, and also maybe to look at what medications they're taking. And of all the biomarkers, vascular ultrasound, particularly total plaque area, is perhaps the most promising technique. Thank you very much.